Again for the kind invitation to present again. I looked back in all the programs since about 6 years, and I was invited to talk here 4 times, and always about perforated veins. And I'm going to tell you this is the last time. I'm going to do it. I'm going to convince you now that you have to treat it in ulcer disease, and then it's done. It's up to you to decide further. So first, something about pathophysiology, that somebody understands why we went after them. Well, we think, and I think at the end of the line we will know, that the incompetent perforating veins are just transporting the high intravenous pressures which are caused by calf contractions to the skin, cause high pressures in the subcutaneous venules, and that's why the hydrostatic pressure goes up, and white cell trapping, capillary cuffing, and all those things appear, and that might influence ulcer disease. So this is why we went after them. There are a lot of trials done in the past, which review articles and also other prospective randomized trials, and they looked at healing rate, recurrence rates, and the follow-up was unfortunately not always as clear as possible. But I know that, and I'm going to look specific at this study that we did, the Dutch SEPS trial, to look at the long-term follow-up, to look at the quality of the SEPS procedure, and then conclude about what you have or have not to do about perforating veins. The problem with all those trials are that they are often combined with superficial vein treatment, and we know that superficial vein treatment alone, like the ESCAR trial showed, also reduces, if you treat the superficial system, you can reduce the recurrence rate of ulcers by 50%. If I look at the randomized trial of Van Gent, didn't show a significant difference between the conservative group and the surgical group, but we took out the lateral ulcers and looked only at the medial ulcers and the recurrent ulcers, it showed significant difference. But if we also looked, and that was, we were, at that time, we were informed by Peter Glowitsky about the registry in North America, and they said, well, it's not conclusive, there's a high recurrence rate, etc. But there was zero quality control after the procedure. And if you look, after you've done the SEPS procedure, and look for if there are still persistent perforating veins or incompetent perforating veins, or if there are new incompetent perforating veins, then you see that there is a relevance of the residual or persistent perforating veins. So your treatment, you can conclude that the sepsis may be not as good as you want it to be, but you cannot conclude from those data that you should not treat perforating veins. In that case, you have to really look at it. And if you look at these data of Van Gent, if we looked at the overall group, we had a follow-up at 27 months. A recurrence rate is 22, but if you look at the incompetent perforating veins which were identified after the procedure, if there were more than one incompetent perforating vein left, then the recurrence rate was 50%, and if only 0 or even only one incompetent perforating was residual after the procedure, the recurrence rate was significantly lower. So this might show that there is some relevance in the persistent incompetent perforating veins influencing ulcer healing and ulcer recurrence. These are the data from the quality of SEPS trial, and then we said, okay, healing isn't influenced, but that's logical. People, when they have an ulcer, they are still compliant to compression, but after the ulcer is healed, they stop wearing their compressive stockings. At least I'm talking for Holland, and I think that the more south you come in Europe and the more warmer climates you have, the worse the compliance is for compression. So after the ulcer heal, they don't wear any compressive stockings anymore, and then you see what's happening here, that there's a much higher recurrence rate if you still have persistent perforating veins. So from this, we thought, well, this is going to happen, and this is happening, so you really should go after it. Another analysis that I already alluded to, if you do a subgroup, which is not really a subgroup, was 87% of the total group of 200 patients in this randomized trial were medial or recurrent ulcers. And in these two, the amount of ulcer-free days was significantly better in the treated group. So we concluded again from these data that the patient with a medial ulcer or recurrent ulcer should be treated for incompetent perforating veins. But you should check after your treatment, or you do it by percutaneous procedures, or you do it with SEPS, or whatever treatment you choose for, check afterwards if you've done a proper job. And if you've done a proper job, then you can expect those results. Now, being about 6 years later, and we have a total, we now said, okay, let's go and look for this trial data for 200 patients and see there are 170 patients and 200 legs treated. And we said, well, let's have a look for after 10 years and find those patients, call them in, do an interview, do a physical exam, do a duplex ultrasound, and again, the quality of life analysis. And that was really, to my opinion, an astonishing outcome. And I will show you. First, we said, okay, what about the ulcers? Because it was very difficult. Not in the first trial, patient kept a logbook and kept in every day ulcer open, ulcer closed for 3 years. But then, of course, that stopped after the trial was done. So if we cut up this data, then we had to be a little bit more easy. And we said, okay, no ulcer and no recurrence. That was one group. No ulcer, but somewhere a recurrence, but no ulcer at the time that we saw them after 10 years. Or they still had an ulcer, and therefore a recurrence, and they had an ulcer but no recurrence because it has been open for 10 years, which is very unfortunate, but unfortunately that still occurs. So if you look at 97 months, that was the average, 72 to 100, so far more than 10 years. We had 170 patients. We saw that 40 patients of those 170, 23% had died. That's more than average, maybe showing that patients suffering from an ulcer are not the most healthiest among our population. And 57 we could not reach because they were just traveling too much. We couldn't find them anymore through the GP or whatever. It left us with 73 people who we could find, 80 legs to analyze and see what it was 10 years after this randomized trial. Well, overall, only 50% was still ulcer-free. But if you look at the surgical group, 60% was ulcer-free. And if you look at the conservative group, only 40% was ulcer-free. So this was a significant better outcome for the surgical group. So we concluded from this that the surgical treated group has a significant higher chance of being ulcer-free after around, let's say, 9 years. Then we looked at the more normal data, which I always present with those if there was ulcer-free time, is healing rates. Well, the healing rates were about the same, which relates, as I said, higher compliance, compressive stockings, etc. But then they stopped wearing it, and then you see recurrence rates. And then you see in the surgical group, the overall recurrence rate is about 50% and about nearly close to 100% in the conservative group. And that was really something which we did not expect to find. And we also looked at the patients who had incompetent perforating veins left. If they didn't have any incompetent perforators, 30% only had an ulcer. If they had one or more incompetent perforators still there or newly formed or whatever, then they had, in 80%, they had an ulcer. So also this shows that if you have incompetent perforating veins, you are worse off and have a bigger chance of getting a recurrent or a persistent ulcer. So in conclusion, we said, okay, surgical treated group has a significant higher chance of being healed and stay healed, and the number of incompetent perforating veins appears to be significant predictor of long-term ulcer status. So in conclusion, and that's why it's my last talk about this subject for the next 5 years, perforating veins do matter and should be treated in patients with recurrent or medial ulcers. Thank you very much.